Envisioning a Better System, Blueprints for U.S. Healthcare Reform. Over the next few minutes, we'll walk through the structural challenges facing American healthcare and explore concrete blueprints for reform. Let's start with the numbers. When we compare healthcare spending per capita against system performance and outcomes across countries, a stark pattern emerges. The United States spends far more than any peer nation, yet delivers some of the least favorable outcomes. This isn't a funding problem, it's a structural one. Part of that structural problem is administrative complexity. Compare a simplified financing system like Canada's to the pluralistic, multi-payer system in the US. The American system carries a much heavier administrative burden and higher overhead costs, acting as a structural drag on the entire system before a single dollar reaches patient care. Coverage gaps compound the problem. Medicaid expansion under the Affordable Care Act was meant to close gaps in coverage nationwide, but adoption has been uneven. Some states expanded early, others remain holdouts, leaving a patchwork of coverage that depends entirely on where you live. Even within Medicaid, states are reshaping the program through complex 1115 waivers. Two major levers stand out: work requirements, which condition eligibility on employment, and trigger laws, which automatically roll back expansion if federal funding changes. Both add complexity and instability to a program meant to provide a safety net. So what are the actual blueprints for reform? Blueprint A introduces a public health insurance option alongside the existing private market. Employers and individuals could choose between traditional employer-sponsored insurance and a public option. It preserves consumer choice, but leaves the underlying multi-payer complexity largely intact. Blueprint B takes a different approach, a transition to a single federal payer. Funds from employers, states, and individuals flow into one central federal payer, which then distributes payments directly to care providers. It's a fundamental simplification of how healthcare is financed. How do these two blueprints stack up structurally? Across administrative cost, system disruption, provider payment, and patient choice, Blueprint A and Blueprint B each carry distinct trade-offs. The public option preserves more of the existing system, while the single-payer model offers greater simplification at the cost of more disruptive transition. One of the most detailed single-payer proposals is the Medicare for All Act. It can be understood through four core components: coverage, defining who is covered; benefits, defining what's covered; transition, defining how we get there; and payment, defining how providers are compensated. Together, these four parts form the engine of the proposal. Beyond financing models, there's a table comparing how Blueprint A and Blueprint B measure up on key structural criteria side by side, giving us a clearer picture of the trade-offs policymakers are weighing. Structural reform isn't just about who pays, it's also about where care happens. Increasing investment in primary care structurally reduces downstream strain on the rest of the system. Think of it as an inverted pyramid. Strengthening the foundation of primary care relieves pressure on emergency rooms, specialists, and hospitals further up the chain. Payment models matter just as much as coverage models. Multi-payer fee-for-service systems create fragmented incentives, while global budget and all-payer models offer more stability and efficiency. Maryland's all-payer model stands out as a successful real-world example of this approach in action. Cost control also depends on filtering out low-value spending. Picture a funnel. Total health spending passes through stages that eliminate waste, apply reference pricing, and evaluate cost-effectiveness, ultimately arriving at sustainable, high-value care. Putting it all together, a sustainable health system rests on three structural elements, much like a building: a foundation of primary care and universal coverage, pillars of efficient payment models and administrative simplicity, and a roof of value-based, high-quality care. None of this analysis exists in a vacuum. It draws on research and legislative work from a range of organizations and government bodies, each contributing data and policy proposals that inform the blueprints we've discussed today. The path forward for U.S. healthcare reform isn't a single blueprint. It's a set of structural choices about coverage, payment, and priorities. Thank you for taking this journey through the blueprints for a better system.